You're welcome to my channel. Thanks for visiting. Today, I'll be going through how to make accurate diagnosis of syphilis in asymptomatic, symptomatic, diagnosed in the past, treated in the past, undergoing treatment right now. All sorts of different cases when it comes to syphilis will be touched right here. Without further ado, diagnosis of syphilis. Let's go. Okay, let's go through this window to have an idea of what this presentation will be all about. Diagnosis of syphilis will take us to serologic tests the most. And here we'll be dealing with antibodies a lot. Blood as specimen, and of course, after lumbar puncture, we'll get cerebrospinal fluid. But it is noteworthy that at the beginning, I'm going to emphasize this, that there is no laboratory culture for the spirochetes, treponemal pallidum, no microscopy culture and sensitivity test, no. We can obtain the fluid from the canker, condylomata lateral, and antepostus, and that will give us the chance or afford us the opportunity of having direct microscopy using dark field microscopy. Yes, we can do that here. And some will go ahead with nucleic acid amplification test with linear chain reaction here. But we'll be talking more about treponemal and non-treponemal a lot. To some that will not be able to go through this while alive because so many people will have syphilis and they won't even know. And syphilis might be responsible for death in them. Like some will even come down with dementia from syphilis, they won't even know. And they will just tag it as, Alzheimer's disease or whatever. So it might be syphilis. Some will have, aortic regurgitation, aortic insufficiency, even aortic aneurysm, dissecting aortic aneurysm, all from syphilis, and they won't even know. Let alone going into congenital syphilis that could lead to miscarriage, intrauterine fetal death, growth restriction, even neonatal death, and they may not even know. But postmortem or autopsy can make that diagnosis after death. Well, with all these facts, in mind right now, let's go and find out how to make accurate diagnosis of syphilis. Why the need for an accurate diagnosis of syphilis? Well, most of the times, people that are even spreading it, they don't know that they have it. Could be asymptomatic for majority of the times and in majority of the patients. And even when it is symptomatic, the symptoms are non-specific, but the complications are dangerous. When we come to signs and symptoms, you understand how syphilis could lead to miscarriage, that is preterm labor, preterm birth, even stillbirth, even death of the newborn, that is neonatal death. Yes, syphilis could cause that. And syphilis could utter so many things in the body of affected individual, from affecting the heart, to the brain, to the liver, to the bone deformity, to the skin, and the list goes on. So it is important to know that this is syphilis because it is so easy to handle it. Just penicillin G. And if there are conditions when penicillin could not be used, we go for cephalosporins. If we can't use that, let's try doxycycline or tetracycline. Although pregnant women could be excluded at that time, some will use azithromycin. So it's something that is treatable. It's a condition that is treatable. It should not be causing dementia later in life, blindness later in life, deafness, and all the dangerous things, destroying the heart and so on. Now, let's give credit to whom it is due. Wasserman in 1906 was the first person to describe fully the serological testing technique for syphilis. And we are going to be basing everything about definitive diagnosis of syphilis on that, besides the direct method, the dark field microscopy. Sometimes we're happy that, we've tested non-treponemal, treponemal, and the results are negative. It might be false negative if the condition is still early. So early onset of syphilis, before the antibodies are fully formed in the blood, it could be negative. Okay, and we might be having what is known as proteasome, reaction, when the antibody is so large and the response is not fitting to what should be gotten, then the reaction is fitting to a false negative in proteasome. When immune is overpowered, immune suppression might be due to HIV. Now, the individual is on chemotherapy, is on steroids, disease-modifying anti-rheumatic drugs, or malnourished. The antibodies are not produced, then it will give us false positive, even though the treponemal pallidum, the spirochete is right there. Then, if that is the case, we have a repeat testing to be double sure. False positive non-treponemal test may be as a result of pregnancy, endocarditis, HIV/AIDS, liver pathology, someone who has just received immunization, those using intravenous drugs, febrile illness, autoimmune conditions like rheumatoid arthritis, Sjögren's syndrome, Hashimoto's thyroiditis, type 1 diabetes mellitus, systemic lupus erythematosus, and the list goes on. What is important to us is definitive diagnosis. So we take thorough history, thorough physical examination, but in this order or in reverse order, you could do non-treponemal test first and then treponemal after. The majority will now do treponemal and confirm with non-treponemal. Either way, whatever is obtainable in your jurisdiction. It's not everyone that will visit the clinic that will be tested. So, who should be tested? We'll take history. If history is positive for signs and symptoms of syphilis, we will screen. If the history is not pointing to syphilis, but the individual is at risk in what sense? Okay, unsafe, you understand, practices as per relationship, or multiple partners, or man to man, you understand what I'm talking about, or this is a pregnant woman, or the partner is already diagnosed with syphilis, we screen. Or this is absent, but why don't physical examination we discover canker or condylomata lata? Then we will swap and start testing immediately. Still on the list of who should be tested, if this individual had been diagnosed with syphilis previously but has never received treatment, today we will have the test done. If this individual had been diagnosed before but had not received adequate treatment, either the dosage or the duration of treatment had been inadequate, we would test today. The individual had been diagnosed before, had been treated, but we are concerned that he or she had been reinfected. Then we will go for full diagnostic procedures today. Still on the list of who should be tested, someone who had been diagnosed with sexually transmitted infection should be screened for syphilis if that has not been done before today. Why? Mostly pregnant and women of childbearing age should be screened for syphilis once any STI has been diagnosed. And anyone with HIV now should be screened for syphilis. Pregnant women, all pregnant women, the first antenatal clinic should be screened for syphilis. Unsafe sexual practices, if that is part of the history, then screening for syphilis is warranted. A partner is already known to be syphilis positive, or the partner is already diagnosed with other sexually transmitted infection, then my patient today before me should be screened for syphilis. Also, there is also in genital area, might not even be in the genital area, might be in the mouth, might be the lips. Please screen today. Or you are able to pick the canker or condylomata, lata, any part of the body, please swab and go ahead with syphilis screening. Tape dorsalis, neuro issue, please screen. Rashes on the palms and soles could be generally all over the body, but on the palms and soles might be something else, but first of all, rule out syphilis. Someone is having chronic headache, you've done everything to make definitive diagnosis, you're unable to get it, you've done your CT, you've done everything, you're unable to get it, please get the non-treponemal, treponemal, or dark field for syphilis today. Someone is HIV positive. Oh, sorry to hear about that, but let me rule out syphilis as well. Those already incarcerated or just released from correctional centers, let's screen for syphilis. And those who are doing this type of job, transactional, you understand what I mean? I don't want to break any of the YouTube rules. I don't want to mention the word directly. Meningitis, particularly aseptic meningitis. Or you are just confused. What is causing this meningitis? You've done your lumbar puncture. Why not just do protein, the white blood cell, then do veterinary disease research lab at the same time? Someone is down with stroke. We don't really know the cause. Screen for syphilis. Cranial nerve palsy without specific origin or aortic insufficiency, and you understand what this is all about? We screen for syphilis if they sign consent. How often are we going to do this? You can be monitoring with physical examination and serology with rapid plasma reagent if we are dealing with early syphilis. In this case, the first visit we will screen for sure, right? Then still the early syphilis, particularly in pregnant women, every first antenatal clinics will screen for syphilis. Then it depends on the severity of the illness, okay? That will determine whether every 2 years in the case of latent syphilis or not. So the first visit will do that. All pregnant women will do that. then it might not be so frequent if it is latent. It can be as late as 2 years or every year, and it could be every 6 months, depending on other factors, particularly if it is tertiary syphilis, still under late syphilis, but with no complications already, then we monitor more frequently, every 6 months. The frequency of monitoring when certain conditions like neurosyphilis with HIV or pregnancy, the follow-up will be more difficult. Then we monitor more frequently, as frequent as every 3 months in those circumstances. And it's better that we start with a particular treponemal test or non-treponemal test and continue with the same. Like if you have started with rapid plasma reagin, then the monitoring will also follow the same pattern. But if it is neurosyphilis and you are doing a lumbar puncture with CSF and you are using VDRL, then the monitoring should be the same pattern with VDRL. When it comes to the tests that we can choose from, let me start with microscopy, culture, and sensitivity. No culture when it comes to Treponema pallidum, the bacteria that is responsible for syphilis. No, the spirochete cannot be cultured in the laboratory. No, but we can depend on serologic tests. In this case, it will be treponema or non-treponema. And also, we are fortunate that we can have the direct method, where dark field microscopy will be pretty useful, and you will see the spirochete live and direct. Also, you can embark on syphilis health check. All these could be done, but no culture when it comes to Treponema pallidum. Now, syphilis health check. This is a form of rapid, quick antibody test for syphilis. The method is Treponema based. All you need is your finger, then you have a prick, and a small blood will be taken, could be performed anywhere by anyone with the skill. But it's not done universally because not many, infectious disease experts will believe in it. Low sensitivity, low specificity. Well, the specificity is a bit high, but then it's not just what is done all the time, so don't waste your time on that. But just to let you know, that's a possibility. The non-treponema test will be rapid plasma reagin, Veterinary Disease Research Lab, and toluidine red unheated serum test. Trust someone? Trust your non-treponema test. Others will be nucleic acid amplification test, polymerase chain reaction for DNA, and of course the direct method dark field microscopy. I will talk more about each of these later on. Uses of non-treponema tests. Pretty helpful in reinfection. If you are suspecting someone has been treated but he or she must have been reinfected, then you embark on non-treponema. In monitoring of treatment, the reason why treponema will be helpful here is that anyone with antibody, treponema will pick the antibody for life. So you don't need it to monitor treatment. In late syphilis, with no appreciable drop in the titer value, then non-treponemal will be helpful in monitoring. Then, example here is rapid plasma reagin 1 to 64. Today is now 1 to 8, meaning your treatment is working. Non-treponemal test in neurosyphilis. Honestly speaking, non-treponemal tests in neurosyphilis with certain factors will be enough. You don't need treponemal tests. Let me explain. Rapid plasma reagin could be used by some authorities, but VDRL, that is Veterinary Disease Research Lab, is better than RPR when it comes to neurosyphilis. So you do your lumbar puncture, you obtain your CSF, and you are going for the white blood cell count. Lymphocytosis is expected anyways, but remember that is not specific. And also the level of protein is expected to be high. Remember that is also not specific. So high white blood cell count, high CSF protein, then you do the VDRL and it's reactive. That is enough to make diagnosis of neurosyphilis. In addition, you may want to go home and have a good sleep. Don't need to bother your head. If you have the resources, do treponemal tests like the fluorescent treponemal antibody absorption test. So that is enough for neurosyphilis. Like I've just stated just a while ago, that when it comes to the diagnosis of neurosyphilis, non-treponemal with white blood cell count and CSF protein should be enough. So if VDRL is reactive and the white blood cell in the CSF is high with raised level of proteins, that is neurosyphilis. But if VDRL is non-reactive and you have raised white blood cell count with high level of protein in the CSF, you can go for treponemal like FTA absorption. If VDRL is non-reactive and the treponemal test is also non-reactive, though you are having a high level of white blood cells and raised protein in the CSF, that is not neurosyphilis. Let me spend 1 second again. VDRL positive, positive white blood cell, positive protein, neurosyphilis. VDRL negative, trepo was done, but trepo also negative, VDRL negative, trepo negative, white blood cell positive, protein positive, not neurosyphilis. You are in a center where you don't have the serological investigation, all of them around, but you have access to nucleic acid amplification tests. So you just swab the tanker or saw or the gumatos, you just swab the lesions. If you have a reactive NAAT, then that is pointing to syphilis. All you need to do next is go and confirm. Confirm with rapid plasma reagin, RPR, or one of the treponemal tests, FTA absorption or TPPA, as the case might be. For polymerase chain reaction, that is helpful, to detect DNA of treponemal pallidum. Polymerase chain reactions to detect the TP-DNA. You can get that done when you swab the canker on condylometer lata or any vesicle from the rashes from syphilis. But you can use any form of polymerase chain reaction, like classical, reverse, transcription, quantitative or whatever. It's not the best in asymptomatic patients. it's having low sensitivity. Either use the blood sample or cerebrospinal fluid from lumbar puncture. Even when it is reactive or positive, we'll still go ahead to confirm that with treponemal test. Definitive diagnosis could be done once using the direct method, like direct fluorescent antibody or dark field microscopy. You just look at the spiral sheet directly. You will see the treponemal pallidum, with spiral, stuff, everything. You just see directly under the dark background. That's very rapid, very quick. You use X-ray, you will see the treponemal pallidum, but it is complex, so it's not readily available everywhere. Now, the list of treponemal tests. They use different antigens. TPPA is treponemal pallidum particle agglutination assay, while MHATP means microhem agglutination test for antibodies to treponemal pallidum, while TPEIA simply means treponemal pallidum enzyme immunoassay, and that is the one that is commonly used or mostly used. FTABS now means fluorescent treponemal antibody absorption. While CIA may not mean what you think of, it's not the one in US, is chemiluminescence immunoassay. Point of care test. Mostly, that will involve the use of treponemal tests. Okay, we've gone through the list of them, right? That would detect specific treponemal antibodies. And what are we aiming at? We want to know if this individual had been exposed before coming to the clinic today. Okay? If it is non-reactive, it means no previous exposure before now. Either reactive or non-reactive. Any positive screening, if it is reactive, should be confirmed with another serologic test. In this case, we'll go for non-treponemal and mostly RPR, because majority will use VDRL for neurosyphilis. When we're faced with discordant non-treponemal test reactivity and treponemal, meaning if both are not following the same direction, if treponemal is positive and non-treponemal is negative, what are we going to do? What we can do is we will use treponemal, another one that is directed at different antigens as away from the treponemal used previously. If the outcome is again that non-treponemal is negative and the treponemal with different antigen is still positive, then we can be having our peace of mind. Probably it is a perfectly treated syphilis case. How about that? Let me explain. Once that antibody is in the system, it's going to be there for life. So treponemal will continue to pick it, but the non-treponemal will pick new syphilis infections. But if it is now negative and you are still suspecting syphilis because the person had contact recently, it might be that it is true. You might be right, but the new infection is at the early stage. Or you are not sure of the contact with syphilis, you are just suspecting what's going on in this life. It might be that other diseases are present. On discordant non-treponema and treponema, if you are strongly suspecting syphilis by treponema as remain non-reactive, then it's likely that you're not wrong. Yeah, the syphilis is there, but the immune system of this patient cannot just react, and that's why we're not getting antibodies. So the immune system might have been overwhelmed. Profound immune compromise. For example, in HIV/AIDS, chemotherapy, steroid use, disease-modifying anti-rheumatic drugs like Remicade, overwhelming malnutrition, and so on. It is likely that the antibodies are not yet built up because the immunity is down. Or something has happened, antibodies have been built, it's not immune compromised state, it's simply because the antibodies are from clump. So we are now at a zone known as prozone. In what order are we going to do all these things? Now, we have a lot of things to do, right? If the history is positive today that this is likely going to be syphilis, and on physical examination, we're able to pick chancre or condylomata lata, and rashes are there at the palm and soles, but we have the rapid plasma reagent down and is non-reactive. What? We're not going to send the patient home. We'll just start empirical treatment today and seek the indulgence of the patient to please come back in a month and we'll repeat the test. Still dealing with what order? In what order? If we have non-treponema first, if it is positive, then we do treponema. But some will go straight to treponema and then confirm with non-treponema. It depends on what you are being taught, in your class. Follow whatever your prof wants, but so many centers do it, the way they like. Treponema first is more common, and then confirm with non-treponema. So for confirmation of treponema, whether or not the non-treponema is reactive. Still going through what order to be followed. If the individual is asymptomatic or there's no risk identified and non-treponema is non-reactive, that is the end of the road. There's no need to waste the money of the patient in the countries where patient pay per everything. That's it. No syphilis. Let me explain again. I'm not going to rush to leave here. Asymptomatic, you cannot identify any risk. The patient has been truthful to herself, himself, and yourself that no contact in any shape or form. You have your suspicion, non-treponema done is non-reactive. There's no need looking for confirmation. You can start with treponema. Like I said, medical student, start with treponema and later use non-treponema RPR to confirm with, or you confirm with another treponema targeting a different antigen antibody reaction. Like if you start with TPPA treponema and you want to confirm with another, you can use FTA absorption. But majority will just use treponema and confirm with another, serological test, non-treponema, RPR mostly. But when it is neurosyphilis, you can start with treponema and confirm with Veterinary Disease Research Lab, VDRL. There are certain interpretations. reactive RPR with positive FTA absorption is syphilis. That is diagnosed. Reactive VDR CSL with high level of white blood cell plus protein is neurosyphilis. I've said that earlier. Positive non-treponemal with negative treponemal will likely be false positive. Past syphilis with reactive RPR and FTA absorption, then check for increasing titers and comments on the treatment whether you are winning or no, you are not winning as per the treatment. No past infection, but both non-treponemal and treponemal are reactive. Then we will treat according to the stage of the syphilis today. If this is asymptomatic but reactive, we will treat as latent syphilis. Treated in the past, that will have a different interpretation. So, treated in the past, let's get all the records today. Let's compare the titers over the months or years to the post-treatment titer. But we must use the same test type. For example, if they have used VDRL before, we have to use VDRL today. If they have used RPR before, we have to use RPR today. Then we'll check the clinical state or whether this patient is pregnant or not, and some other associated risk factor or factors, because we are treating the human being, not the laboratory record alone. Still on some possible interpretation, this individual had been treated in the past. Treponemal will remain positive for life. Non-treponemal should be dropping in titer values as the months and years will pass. If non-treponemal is increasing in 4 folds, then we are dealing with syphilis again, regardless of the treatment in the past or now. The non-treponemal, after a time, will wane and become non-reactive over a time. But treponemal will remain positive for life. If non-treponemal is reactive and treponemal is also reactive, then query the following. Number 1, is this full syphilis diagnosed? Okay. If prior history of syphilis is in this same patient and RR is positive with maybe TPPA, then what is happening clinically? We have to check for the physical examination clinical state of this individual and then compare the ratio of the titer to what it was at the beginning. Then embark on our treatment appropriately. But if both are positive like this, it may be false positive, like in certain conditions, like autoimmune conditions, Nobel or yours. If non-treponemal is positive and treponemal is negative, it's likely going to be false positive. And I will not waste the time. Please check, rewind back, check again. I've stated false positive conditions. And what I'm going to do here, we'll let the test be repeated in 3 months. Some will choose 6 months, but the clinical state will determine. If the clinical state is bad, you don't let the patient go untreated. With that, I've come to the end of this presentation on how to make accurate diagnosis of syphilis. Thanks for listening. Check my other presentations on this channel. I appreciate it. Please remember to subscribe. I appreciate it.